Okay.
Because I know Dr. Sushma is
Hello,
always
hello.
on time. Yes, madam, over to you, please.
Good morning, everybody. Welcome you all for a important session of a day where we will be discussing the important aspect of severe endometriosis management, about genital tuberculosis, which is again a common condition. I think there is some change in the third topic. Oh, yeah. Okay, thank you, thank you. I know that Sushma doesn't need any introduction. She is our NOGS president and she had made her niche in an international level with her hysteroscopy. I invite Dr. Sushma, please.
Very good morning to all. I'm the opening batsman of this series of academic session. And the topic, and really, first of all, I would like to thank to our NOGS family and the MSR for organizing such a wonderful conference, and gathering is really fantastic. So, well, the topic is given to me, management of severe endometriosis. Actually, I was listening to Dr. Neeta, and she had made my job very easy by giving all the guidelines, history guidelines. So I will skip that part, but there are very interesting videos I would like to share. First, we know that the endometriosis is a notorious player because some diseases are like a mystery. Patients are in agony. Doctors are uneasy, trying to treat this way and that way. Patient symptoms are confusing. Dysmenorrhea is not responding, and patients suffering from infertility. Doctors are suspecting, but diagnostic tests aren't convincing. If diagnosed, management is disturbing. And due to recurrence, it sometimes becomes very frustrating. And sometimes something somewhere, a notorious player affecting the health and justice. Friends, think about endometriosis. So we know that it is an enigma, already well discussed by Dr. Nita. I was listening all the discussions. So we know that it's a continues with the plethora of presentation of lesions, signs and symptoms. And the most important symptom include pain and infertility. And the various theories are proposed. I am not going in detail. And the prevalence ranges from 2% to 10% in general population and 50% in female. Already it is said that there is no such diagnostic tests are available, but still we think that the laparoscopy is a gold standard and efficient treatment. But always remember that it is not necessarily effective therapy. So what are the important concerns? There are very much important concerns regarding the diagnosis, because we should have a high index of suspicion while treating our infertile patient or any patient, especially adolescent girls. Because there are gynecological symptoms or non-gynecological symptoms. Gynecological symptoms like chronic pain, dysmenorrhea, dyspareunia, and also there are non-gynecological symptoms. So they should alert us that this girl or this lady can have endometriosis. So the other symptoms I'm just mentioning, like clinical examination, transvaginal sonography, these symptoms we see in the severe grade of endometriosis. Like clinical examination, painful induration nodules over the posterior wall of vaginal wall. And the transvaginal, you can see the endometrium very well. The typical stippling you can see. I'm going to show all these features in the hysteroscopic and the laparoscopic findings. Very interesting case studies. And the laparoscopy with positive histology is considered to be gold standard. Remember, not only laparoscopy, you should take a biopsy. Another is always laparoscopic staging, and grade 1, 2, 3, 4, minimal, mild, moderate, severe. Just I am briefing everything. And the biomarker testing not recommended, and the negative imaging results does not rule out endometriosis. Remember, because grade 1, 2, 3, you cannot diagnose small lesions by sonography. Now, the already stages described very nicely. I will just like to mention one thing. So we know all these grades. So if we see the various grades like stage 1, 1 to 5, stage 2, 6 to 15, and the stage 4 more than 14. Why there was a need of such so many guidelines and the classification? Because if you see this one, can I have this pointer? This is a cul-de-sac obliteration. They have given the complete, if it is obliteration is complete, they have given the 40 score. And suppose we see that if only there is a cul-de-sac obliteration and the tubes and ovaries are normal, it can't explain, because the main treatment for stage 3, stage 4 is a direct ART or like that. But suppose tubes and ovaries are normal, then patient can conceive by the similar ovulation induction and the IUI. So that's why it doesn't explain the properly. So that's why there is these diagnoses that already Neeta has very nicely mentioned, that the endometriosis fertility index and the least function score is the actually key component of EFI score. So accordingly the score is there. Already we are knowing about this score. I will move ahead. So these are the very important guidelines. One must know everything given in detail by the guideline development group. So accordingly, there are even the good practice points are also there. So we can very well treat the patients of endometriosis. Now, before wasting time, we just now how to apply in these clinical situations. Because sometimes, these guidelines becomes very boring and sometimes very exhausting. But you have to read it properly, very nicely given, and now we have to apply. Now, this is nowadays what we are observing. Many young patients are coming with the young adults and girls, UA girls. They are coming with this endometriomas also, a severe grade. This is a young 33 years unmarried girl with severe dysmenorrhea, admitted with a severe pain in abdomen early in the morning, not getting relieved with any analgesics, hardly temporary relief. Initial management, she was managed with the pain management, and when the investigated, she attained menarche 14 years back, but since 5 to 6 years, increasing dysmenorrhea. Then on general examination, there was a lump arising from the pelvis 16 to 14 weeks. And the previous USG dated back 2 years back, bilateral endometrioma of 3 to 4 centimeter. But she was not under regular treatment. And when the current USG was showing the bilateral endometrioma of 7 to 8 centimeter, CA 120 was done, it was 56. And now what is the plan of treatment for such patients? Counseling of the girl and her parents, which is very, very important. Further, because nowadays these girls are very much career oriented, and the further fertility aspect we discussed, AMH for the ovarian reserve, and the surgery followed by medical therapy. These are very nicely given in guidelines. This is strongly recommended. In adolescent with endometriosis, clinicians should consider post-operative hormone therapy, as this may suppress the recurrence of symptoms. And again, while performing surgery for ovarian endometrioma, specific cautions to be used to minimize the ovarian damage. So this is very important. We have to be and there should be no only drainage, because it will again have a recurrence and it will again have a endometriosis associated pain. So you have to inoculate and remove the cyst. Unfortunately, I am not having the video, but the girl is since 5 years she is under follow-up. I have given her Dinoges for 2 years. Then again she lost in follow-up, but just hardly 3 months back she came to me, and there are now small 2 to 3 centimeter endometrioma bilateral. And now she is 31 years old, but still she is not planning to get married. Now what is the main, catch them earlier, which is very important. So, and it should prescribe the hormonal, because diagnosis only with the high index of suspicion and according to the history. So it is a strong recommendation. You should have we have a ectopic minded, there's an endometriosis minded, this term is coming, so we should know, suppose this patient is having this complaint, so you should always think about endometriosis, and you can directly start on the progestogens or the hormonal contraceptive therapy. Now the situation 2. This is a 31 years old patient, married 5 years back, present with the pile of files, is a typical way. She is under treatment of infertility since 3 years. She was having dysmenorrhea, chronic pelvic pain since 7 to 8 years, and she was also having her previous reports. Ovulation induction done 6 to 7 times, IUI was done 3 times, HSG was with her, which was 3 years back, it was normal, but AMH was 1.5. And the transvaginal sonography, bilateral complex ovarian cyst 5 to 6 centimeter, and she was from Yavatmal, so she's from Yavatmal, so the CA 120 was done, because they were thinking there can be a ovarian tumor, and it was 87. So they were very much scared, and they rushed to Nagpur, and they wanted get it done as early as possible, because this is a hardly young lady, husband evaluation was normal, and the rest investigation were normal. So you can see, now I would like to show this video. Now what is the plan of treatment? Direct ART, trial for laparoscopy, and if ART, what is protocol? Now this patient already having the complex ovarian cyst. So basic idea is to give her a plan for trial for laparoscopy, and generally we do hysteroscopy before doing any IVF or ART. So which is very important because already the patient was in agony, they were so much scared. So I planned laparohysteroscopy. So you can see, we start with the vaginoscopy. You can see the endometriotic nodule. See, rarely you will get an endometriosis. Directly you can see it is a case of grade 4. See, typical in the posterior wall. Now slowly we enter in the cervical canal. You can see very nicely cervical canal. You need not touch anywhere. Slowly you have to navigate through the cervical canal with the normal saline. We are using with 2.9 mm hysteroscope. See the arbor vitae. It was very difficult, though it was looking easy. At the internal os, I was trying to get in the uterine cavity. It was narrowed. Though cervical canal appearing normal, it was very difficult to negotiate and to reach in the uterine cavity. And now you can see interesting findings. See, these are micropolyps. See, this is again one more micropolyps. Typical of chronic endometritis and present in the endometriosis patient. See, one more micropolyps. This endometrium is, see, 2 micropolyps. So you need not touch anywhere. And this is the patient, actually that was 11th day of her menstrual cycle. Generally I do hysteroscopy post-menstrually, but she was really in agony, so I had to do it. So see, so many micropolyps are there. So these findings are conformity of the chronic endometritis, and you have that clue that the patient can have, even while doing hysteroscopy, you can assume that patient can have endometriosis because of these findings. Now we'll see what is happening in the C. This is the in the laparoscope. When we put the laparoscope, completely this, you cannot see the endometriosis also. Even the complex ovarian cysts they are mentioned. See, completely bowels and omentum adherent to the posterior wall. You can see this is the cyst, left cyst. And if you observe it directly, that omentum, these are the typical kissing ovaries, and this omentum is adherent in between the 2 ovaries. So actually you can see the small lutein cyst also there. So sometimes what happens, there are 2 strategies. You can directly puncture and suck that endometriotic material. That is, water therapy is very important, irrigation. But somehow while doing it, just I can show you that. It was slightly got punctured. It's very friable mass. See, diagnosis is clear. That's the case of clear-cut case of endometriosis. So you have to enucleate and remove the cyst. And avoid cautery and see. This is the picture final. Now this patient is planned for ART. What can be the protocol? So protocol is the extended administration of GnRH agonist prior to ART treatment to improve the birth rate in infant women with endometriosis is not recommended. You can use the normal protocol as it is. Then there is insufficient evidence to recommend a prolonged administration of the combined oral contraceptives, and even the clinician should not prescribe the ovarian suppression treatment for improve the infertility. Then the situation 3. This is a 36 years old hefty lady, height 171 centimeter, weight 87 kg, typical career girl, high post at airport, and they are staying since hardly 2 years to be the husband and wife. And ovulation induction was done many places at other places, and very much anxious to conceive. AMH 1.2, AFC 6 to 7, and the blood pressure is 140 to 80. On gynec exams, the mobility of uterus restricted and appear to be adherent posteriorly, USU showing bilateral endometriosis of 3 to 4 centimeter. Now, in my total career, hysteroscopy career. This hysteroscopy was really terribly difficult. It was a thick adhesion posteriorly. I will show the video directly because she was planned for hysteroscope, the ART. Now you can see this is the edited video. This is the, sorry. See, I was just unable to enter in the uterine cavity. It was so snugly adherent posteriorly. Even my hysteroscope had bent because of this patient. I was just trying to go in the uterine cavity. See, I am in the cervical canal only. It was very difficult, very small. The cervical canal also very narrowed. And you can see I reached just above the level of internal os. This is the entry wall of the uterus. And the posteriorly it is like that. So I was trying to reach, but I could reach up to the mid cavity only. Because you can see the various, I tried a lot to get into the uterine cavity. Now this my pointer will move here and there. Actually, it's an edited video. See, I'm trying to move my pointer like this. And you can see this cannot get this picture. And the whitish structures are there. So, but fortunately, this patient conceived with the one embryo. Is a very lucky patient. I was not having that because hardly we got 4 oocytes, but she conceived somehow, I don't know. So what is the GDG recommends that the decision to perform surgery should be guided by the presence or absence of the pain and symptoms. Another, patient age and preferences, history of previous surgery and the presence of other infertility factors. Now it is very much clear that the clinicians are not recommended to routinely perform surgery for ovarian endometrioma prior to ART to improve the live birth rate, as the current evidence shows no benefit and the surgery is likely to have negative impact on the ovarian reserve. So they are recommending that when you are getting such patient with the low AMH, with the big endometrium, you directly start with the ART. No need to do laparoscopy, because that the same thing I did with this patient. So that there are other non-medical management strategies are effective. There will be no benefit to increase the chance of pregnancy. So as we are running short of time, so is just 1 minute. Endometriosis is an indication of fertility preservation. In the case of extensive ovarian endometriosis, clinicians should discuss the pros and cons of fertility preservation with women with endometriosis. The true benefit of fertility preservation in women with endometriosis remains unknown. So basically you have to start the treatment. So this is an infertility patient. Different options are there. Hormonal not recommended. Only surgery and the medically assisted reproduction. So it is a surgery is good. Grade 1, grade 2. You can start with the natural conception or IUI, or it's a grade 3, grade 4. Directly go to the medically assisted reproduction. So these are my various books. Actually, you can go through the 3rd edition. I have mentioned so many things of current advances, recent advances. Thank you very much. I think I completed. It was a very vast topic, but I tried to complete in these 15 minutes.
Thank you, Sushma, for a very detailed talk on endometriosis. You said unmarried girls not wanting to marry, coming up to 31 years. What about her? What advice on ovum preservation after she gets married?
Yeah, actually, I have a thorough discussion with the girl and her mother. But that mother is also really fed up of, because luckily that girl still having AMH 1.2. Even though she is having such a recovered from all these endometriomas. Now the girl is, I don't want to marry. I want to do my career only. I am not interested in pregnancy or like that. But still, we should counsel them. I was telling her, see, now your parents are with you, but what will happen after 10 years, say after 5 to 8 years? But she said, no, I'm okay with that. I'm happy with my career. And so many girls are coming up like that. And she is not willing for the oocyte preservation also. I have given all the options to her.
Thank you very much.
Thank you, Sushma. We all know with advances in preventive medicine and advances in diagnostic aid, Genital tuberculosis is still a common condition, especially in India, and it poses a diagnostic dilemma. I invite Dr. Sanjeev Khurd, our friend from Pune, to enlighten us on genital tuberculosis. ये तीसरा वो अभी तक ऐप पे बोल ये टॉपिक पे बोलेगा हाँ इनवाइट कर
सेशन खत्म हो जाए
इनवाइट कर फिर से फिर से ये तो मैं बोली सोती ही रहेंगे आप माय गॉड
Respected Madam Purvar, Madam Taide, Dr. Fizbi sir, it's a pleasure and honor to have chairpersons like you. And thank you very much, Chaitanya, Sadhana, and the team for this invite to be here at this wonderful city of Nagpur, which I always enjoy. Genital tuberculosis, well, probably we need to now understand about there are new guidelines also that have come for diagnosis and management of genital TB. The moment you think of genital TB, there are certain few things that really come to your mind. Number one, affection of the tube. And when it comes to pregnancy success, it's all tears. Spontaneous pregnancy is rare. In case you give antitubercle treatment, the success is below 20%. Do tuboplasty, it's less than 5%. And then first trimester miscarriages, preterm labor, live birth. Even if you do an IVF, the success that was mentioned by Dr. Firoza Parikh was just less than 16%. Of course, some data did show a better success because you had good selection of the cases. And in our own IVF center, what we found, our success rate when it comes to genital tuberculosis is 10% lower than what we normally get in patients who do not have genital tuberculosis. So overall, it's a sad, dismal state of affairs. Now, why so? Because genital tuberculosis is a silent, stealthy invader, and it causes devastating damage before the condition is even suspected. That is the reason. The infective state quickly goes into the disease state, and it damages the fallopian tubes and the endometrial cavity. So there is a need for reliable method of early diagnosis and elimination of tuberculosis infection so that the infection doesn't progress to the disease state, which will affect the tubes and the endometrium. So we have, as clinicians, we have a lot of questions. So our quantiferon TB Gold or Gene Expert, the gold standard for diagnosis of genital tuberculosis, is Monto an outdated test. So can I start antitubercular treatment just with positive TB PCR report? Should I repeat TB PCR after completing the antitubercular treatment? Can I give empirical antitubercular treatment or a short course? Can I do that for 2 to 3 months? Or will a second course of antitubercular treatment be better once the patient has already been given a course earlier? Are anti-TB drugs safe in pregnancy and to the newborn. So these are various questions clinicians we have in mind. We'll address them one by one. Now, tuberculosis is an age-old disease. Ayurveda mentions, the Charak Samhita mentioned, which is 200 before Christ, something known as Raj Yakshama. See, this is tuberculosis. When it comes to genital tuberculosis, in 1774, Morgany was the first to describe. There was a patient who underwent postmortem and there was a uterus and tubes which were filled with caseous material. So that is genital tuberculosis. But it was father of bacteriology, Robert Koch, in 1882, who discovered the tubercle bacilli. And in 1993, WHO declared tuberculosis as a global emergency. Why? See, because even today, the recent WHO data shows that 1 out of 4, remember, human beings are infected with the bacilli and at a risk of developing the disease. And what they have stated that 5 to 10% of the population with tubercular infection will eventually have tuberculous clinical disease sometime or the other in their lifetime. Now, WHO mentions 3 states of tuberculosis. One is tubercular infection, that you have the tubercle bacterium present, but not active. So this is called as a subclinical, or popularly called as a latent tuberculosis. Tubercular disease, where is an active TB and with a clinical presentation. And of course, reactivation of the disease, when activation of disease in an individual who was earlier treated with anti-tubercular treatment. Now, these are 2 words which keep on always surfacing, and we need to know the difference. Latent TB is an infection, while active TB is a disease. In both cases, you have the bacilli which is positive. Now, there is no tissue damage when it comes to latent tuberculosis. That is something what we need to understand. While in active TB, you have the tissue damage that has occurred. This is subclinical, this is clinical, this is asymptomatic, while this is symptomatic. And the organ affection is negative, while here you have the lungs being affected or the tubes or the endometrium being affected. Now, we need to understand that what is mentioned are 2 states of genital TB pathogenesis. One is known as a primary genital TB, which is rare, and it happens when the semen is infected with TB and then causes lesions of the cervix or the vagina. But most common, and that we normally see, is genital tuberculosis, which is always secondary to commonest is pulmonary tuberculosis. Uncommon is genital pulmonary foci as well, and occasionally a part of miliary disease process. The primary focus, which is there in the lungs, becomes quiescent after the TB infection, and there's a long latent period of 5 years, 10 years, and then it goes and affects the fallopian tubes. So that's the secondary stage of the genital tuberculosis. And 5 to 13% of pulmonary tuberculosis develop genital TB, and 10% of extrapulmonary TB develop genital TB. Now, mode of spread, we know it's hematogenous or lymphatic or direct contact. And initial infection, remember, in almost always the fallopian tubes are affected. So this is the hallmark of genital TB. The tubes are affected. And then by secondary extension, the damage occurs to the endometrium, ovaries, cervix, vagina, and vulva. Now, we are a tuberculous country. There is no denying of that. For 20% of our population is affected with TB. And what we need to understand that there are missing cases. More than 10 lakhs that has been stated, and this is an underestimate. That is what the authorities really agree. So about 18 lakh new cases of genital TB every year, of new cases every year, and 85% of them are pulmonary. And what is important, 3 to 15% of pulmonary TB develop into genital tuberculosis. Well, urogenital TB makes up 4% of all extra pulmonary tuberculosis. Now, this is very important, that if you restrict or if you control pulmonary tuberculosis, we are going to get lesser and lesser number of genital TB. So the focus has to be on decreasing the number of pulmonary tuberculosis, and that will help. And this comes to various ways. And one of the ways is what our Pune Obstetric Gynec Society does every year on 24th of March, which is World Tuberculosis Day. This is a poster exhibition at the famous Dagdushet Ganpati temple, where thousands of people come. So as it is, we get an opportunity to educate them about this disease. Now, in our clinical practice, how often do you see tuberculosis? Now, various studies mention somewhere between 3 to 16%. Now, what I have seen in my practice for the last more than 30 years, we used to see a lot of genital tuberculosis early in my practice. Most of them came from rural area. But today, I am seeing less and less amount of genital tuberculosis in our practice. Now, this is basically a city-oriented practice. I'm not aware about what happens in the rural area. And when it comes, as I mentioned to you, it's tubes that are affected. And in 30% of the tubal affection, it is genital TB. And the damage occurs because of the active disease or when fibrosis sets in. Now, diagnosis of genital TB. Remember, high index of suspicion. Think tuberculosis, as always. Well, but we must understand that there is a difficulty in diagnosis of genital TB because of the paucibacillary nature of the disease when it comes to pulmonary tuberculosis, where it is teeming with bacilli. So the index TB guidelines 2016 mentioned that confirming the diagnosis of tuberculosis is very difficult. And conventional diagnostic methods of microscopy and culture have low sensitivity. So how do you make a diagnosis in our practice? Well, clinical suspicion. Then you have tests to detect the immunological host response which the TB bacilli generate. Then tests to detect the post-inflammatory organ damage because of the disease. And of course, the confirmatory tests are tests to detect the presence of the acidified bacilli directly. So this is like a thief, you know. The thing is, you have gone to a movie late night, come down, and it's all dark. There's a suspicion. Oh, and then your dog is barking. Well, then probably, yes, this is the response. And when you enter the house, your house has been burgled. So this is the damage. But you must catch the thief. That's important. So how do you do that? Suspicion, it comes from history. The patient comes with a history of pulmonary tuberculosis, especially if there's a abdominal tuberculosis, think genital tuberculosis. Symptoms, there are chronic pelvic pain and menstrual disturbances. But most in our practice, they come as, they present with infertility alone. When you examine, most of the times the findings are normal. But if you have pelvic masses, think of tuberculosis. Now, the test to detect immunological host response, well, we have two tests, the MON2 and the interferon gamma release assay called as the IGRA. Remember, these are screening tests for tuberculosis. Now, they are not specific to genital tuberculosis. The bacilli could be anywhere in the body, and it is important to confirm by confirmatory tests. So that's again important to understand. The MON2 test has been an age-old test, more than 100 years old. 55% sensitivity and 80% specificity at laparoscopically diagnosed tuberculosis. We must be aware about false negative and false positive tests. False positive especially because of BCG vaccination. So when it comes to that, the IGRA scores over MON2 test, and it is preferred test in population which is where BCG vaccine has been given, and we all have received BCG vaccination. Now, serological test to measure the immunological response of host to the specific antigen, to Mycobacterium tuberculosis. We have two tests, quantiferon TB Gold and T-spot TB test. Now, what is important? They have high negative predictive value. This is where we must understand the value of these tests. So, if the test is negative, then the bacilli, that means genital tuberculosis is unlikely. Of course, specific sensitivity is impossible to determine. Again, I must say that these tests which were performed very routinely are banned, the serological antibody testing. Now, how do you detect the damage to the organ? Well, we have various modalities, right from X-ray chest to MRI. And most important for us gynecologists is the DNC, which we combined with endometrial biopsy, the histosalpingography, which is combined again with the DNC, or you have a combination of HSG, histoscopy, and a DNC, and of course, histoscopy, laparoscopy combined along with a biopsy. Now, we must understand endometrium is involved in 50 to 60%, rarely 90%, some studies have mentioned. So it's accessible. So this is the area of first area to diagnose genital tuberculosis with priority, and then make a confirmed diagnosis. So diagnostic curettage is performed premenstrually or within 12 hours of onset of menstruation. And most important, you try to reach the cornu because that's where the bacilli would be present in a larger way. Now, what the test that you perform? Staining and microscopy to detect the bacilli directly. Send for culture. Now, earlier we knew about the solid culture medium, but of course we are not using that. Today we are using the liquid-based growth culture. Earlier we were using the radiometric, and now you also have the non-radiometric in form of microbacterium growth indicator tube, the midget 960. Then these are tests are popularly tests, the PCR that we normally would subject to. Now PCR, it could be the DNA PCR, the RNA PCR, again the ribosomal messenger PCR with gene sequencing. That is something that has got the news. The expert, where it detects the rifampicin resistance as well. And of course the histopathology examination. Now, we must understand the limitation of this test. See, the thing is, just because the test is negative, that does not mean the patient does not have genital TB, because the tubes are have almost always affected, but not the endometrium. So, we must look for a negative test of genital TB on endometrial sampling does not rule out the presence of TB bacilli, and we must use this report in correlation with the findings of the other test. The ultrasound, the HSG, the laparoscopy, hysteroscopy, this is all that we have been using. And there are various markers which will say, whenever you have the cogwheel appearance or a persistently thin endometrium, think of genital TB, the beaded tubes, the hydrosalpinx, the extravasation, intravasation on HSG, whenever you have miliary tuberculosis, the perihepatic adhesions, they are again telltale signs of genital tuberculosis. Of course, we understand it could be chlamydia also. So you need to use all in combination. And intrauterine synecdoche. Now, this particular scar cavity is a cavity which I saw very early in my practice. I have not seen this later. So, this is genital tuberculosis. It came with total amenorrhea. So, detecting the presence of TB bacilli, you have microscopy, the culture, the BACTEC, or the midget, and the PCR, of course. And PCR is the most sensitive, most specific, and quick test to diagnose the presence of TB bacilli. And now we have the expert. See, the thing is, all these tests, remember, apart from microscopy, all these tests take time. But this is the expert. The report comes less than 2 hours, and that is the big advantage. Along with, of course, you have the resistance to rifampicin, which is now this test is performed by using this instrument system. And these rapid molecular tests are now the order of the day. Also sequencing to detect mutations associated with drug resistance. The CBNAT, which is the cartridge-based nucleic acid amplification test, which also tells us the resistance to rifampicin. And we have the line probe assay, which tells us resistance to rifampicin and the INH. These are all PCR-based tests, which give the reports rapidly. Now, 10 years ago, I had organized a conference, one-day conference of genital tuberculosis. And so where does TB-PCR stand? Where did it stand that time? Well, the CDC mentioned that it is not yet investigation of choice to diagnose genital tuberculosis. And you should not start or stop treatment just on this single report. And then the Index TB guidelines, which came in 2016, also mentioned the same thing, that evidence is not enough. And today we have the latest guidelines, 2021, which comes from our own government of India. It mentions that microscopy positive, culture positive, expert or other NAT positive or HP positive means this is a confirmed diagnosis of genital tuberculosis. So how do you make a final diagnosis? Well, as I told you, if you have a confirmed diagnosis, fine. All these tests, any of them is positive, is genital tuberculosis. But remember, it's not always possible. So you have suggestive markers also on your, what would I say, investigations of modalities. The sonography, hysteroscopy, laparoscopy, and probable markers as well. Now, most important, we must understand that these definitive markers are not always positive because of the possible nature of the disease. So we have to take recourse to the pointers from clinical suspicion, suggestive diagnosis, and probable diagnosis. And what most experts feel that even if you have 2 markers, then you would label them as a case of genital TB, because the definitive confirmative markers are not positive in most of the cases. And that is the reason we have to take recourse to the other markers. And if there is no evidence on microbial, HP, imaging, hysteroscopy, laparoscopy, the government guidelines are female genital TB is negative and no anti-tubercular treatment is to be given. So this is something very important. So when it comes to treatment, we know about the RNTCP. Now,
A kind request. Dr. Kundan is also here, the third speaker.
Just give me a minute.
confirm.
Yeah, that's right. Thank you. So now the latest in the treatment are what is known as National Tuberculosis Elimination Program. So strategically to reduce the burden of TB by 2025. Now when it comes to treatment, there are only two groups. One is the drug-sensitive tuberculosis and the drug-resistant tuberculosis. Unlike the category 1, 2, 3 that we had earlier. Now most genital tuberculosis would fall into the earlier category 1, the drug sensitivity. And we know the treatment, of course, giving 4 drugs for 2 months and 2 drugs for 4 months. So at least 6 months. Now short-term, can I give a short-term trial for 2 to 3 months and see whether the symptoms resolve? Well, I think it's very clear. Minimum 6 months have to be given, and there is no place for a short-term trial of anti-TB treatment. Now, empirical treatment, well, the Index TB Guidelines 2016 did mention that yes, you could give if there is only infertility. But the latest guidelines clearly mention if there is no evidence, no anti-TB treatment has to be started. Now, I don't know, the video will play. So when you see these adhesions in the abdomen, subhepatic the subdiaphragmatic adhesions to the liver, think of genital TB. The look of the tube itself, the pale appearance, the indron fimria, see, they are all suggestive this is case of genital TB. It could be other organism as well, but this is genital tuberculosis. And of course, now this is a patient which will go straight for IVF. So here, what is important, you need to de-link the tube or excise the tube. So both treatments are fair enough. Now, success of...
Sanjeev.
I'll just finish off. So now in this case, this patient was given a course of anti-TB treatment. Should I give a repeat anti-TB treatment before I start the IVF treatment? No, it's not to be given. That's important. Now, the drugs that are to be used in case the patient becomes pregnant, there is a patient whom you suspect tuberculosis or has confirmed tuberculosis and you give treatment, she becomes pregnant. The first line treatment are absolutely safe. Streptomycin is not to be given. Breastfeeding is not contraindicated. In case she has pulmonary tuberculosis, then wear a mask, of course. Now, it's a notifiable disease. That is what, again, we must really important. And we must inform each and every case of tuberculosis that we are treating. And of course, Amitabh, we all know, has been the brand ambassador he himself had tuberculosis. He was bold enough to admit, and that really helped in the creating awareness of this disease. So thank you very much for your patient listening. It's a topic which is, I would say, controversial. Yesterday, Padmarekha mentioned about 40%, and that was something that I would really be interested to know, the method of diagnosis and how you probably, what are the tests that were involved.
Thank you, Sanjeev.
So thank you.
For a very detailed talk on tuberculosis. But in my experience and in my EA, ultimately, after 40 years of practice, it's very difficult to say or diagnose. Even your net tests are majority of the time negative. 1 or 2, 3% would come as positive. That's what I know. And depending on the clinical findings, yes, HSG is very important. We shouldn't forget. Hysteroscopy, we are doing fine. But HSG, there are so many things. Irregular uterine cavity, endometrial lining is one of the important thing for tuberculosis. And because for starting anti-TB treatment, you have to be a certified person to start that.
Very true.
And so in majority of my patient where I find all these findings are there, but the tests are negative. You said the government says, don't give anti-TB, yes, right? So what I do is I explain to the patient, Bhaiya, you are not tubercular. I am empirically starting this. And you start this treatment, and sometimes on treatment, the patient conceives with it.
Sir, the government guidelines are negative in all. That means not only these markers, but also hysteroscopy, laparoscopy is also negative. Then you don't start. See, most of the time the problem is we see peritubal adhesions. We see adhesions, and the other tests, the confirmatory tests are negative. So therefore, most experts feel that if you have, say, the patient has a previous history of pulmonary tuberculosis, and you see findings in the pelvis.
All right, just a small interruption, because actually Dr. Sanjeev was thinking that the third speaker is not there, but we have the Superman, Dr. Kundan Ingle, who was actually at the third hall taking care of the free papers. That's why he did not answer my call. So now he is here.
Okay.
So can we please have
Fine.
Dr. Kundan English? Yes.
So I'll just complete it. So if you have two markers, then probably you are justified in starting antitubercular treatment. Thank you.
Thank you. Our next speaker is
I
Dr.
invite Dr. Kundan Ingre. I am Dr. Kunda. Let me invite Dr. Kundan. He is going to talk on declining fertility.
And he's also going to try to finish it in 7 minutes. As I told you, he's a Superman.
Good morning, ladies and gentlemen. I think this topic, which was declining fertility, probably I thought while preparing this presentation, I was thinking that what should be the direction and content of this topic, especially. So I think today my aim of presentation is somewhere we are trying to find out reasons to tell our patient that why my fertility is declining, or especially why my ovarian reserve is declining. What are those important points which probably it may not help us to change that ovarian reserve, which is kind of a irreversible change, but we can find out some reasons that why we are seeing these patients who are significantly increasing in percentage, having very low reserve in kind of prematurely. So this was a recent by WHO global infertility prevalence estimate, and they wanted to try and find out what is happening globally about the fertility rates. So they had two types of estimates. One was kind of a lifetime prevalence, and that is defined as a proportion of population who have experienced infertility in their life. So that is a lifetime prevalence, and there is something called as periodic prevalence, meaning at particular period or particular time interval, what was the prevalence. So their conclusion that 1 in 6 people, they are experiencing infertility at some stage in their life, and the calculation is around now presently is 17.5% as a lifetime prevalence presently. Now, same data try to find out what is happening in different countries. So we go in that WHO Southeast Asia region, and unfortunately, we really did not have any estimate because there was no data from our region. And the rest of the countries, they found it in a range of say 5 to 15%. In certain European countries, it was very high. So United States of America and European regions, they reported the highest prevalence of lifetime infertility, prevalence of infertility. Now, this is a kind of a data where we what is to happen in 1951, that is around 70 years back, that number of children for one particular woman, there that time used to be around 5 per woman, right, for a couple. Now that is significantly showing a decreasing trend, and now recently in 2020 says that on an average around 2.4. So that probably number of children which woman is on an average is having is also number is showing that it is declining. So according to this survey, the country's fertility rate has come down to 2 from 2.2 in our National Fertility Health Survey, and that was in 2015-16, and between 2005 to 6 it was 2.7, and they found that this is typically happening in urban areas more rather than rural area. So probably we have to see what is happening into urban areas. So that is the area. Now we know that age-related decline in fertility is it's physiological. It's not pathological. It is there. We know that. So what are those problems with that age-related decline in fertility? So it is basically detrimental impact of various aging process on female gametes. So it's a problem with the gametes. So declining numbers is one, and also deteriorating quality of oocytes with increasing incidence of meiotic errors and aneuploidy of gametes and embryo. And that's why we see a lot of pregnancy vestiges in elderly patients. So increased fetal aneuploidies in ongoing pregnancies and increased predisposition to obstetric morbidities all is contributing into poor reproductive outcome. So what we see is there is an increase in frequency of euploid and aneuploid spontaneous miscarriages with age, and meiotic spindle assembly is more frequently abnormal in oocytes from older women, and greater proportion of degenerative oocytes we are seeing in older women. So, friends, we know that the cutoff is for, kind of elderly, where the significant decline in the fertility starts after 35, 36 age. And the reason is on the right side chart, where we see number of oocytes present in the ovary. At the age of around, say, puberty, it was 3,000 to 3 lakhs to 5 lakhs. But at the end of 37 years, they are only 25,000. By end of 51 it is only 1,000, and that's why that kind of menopause age limit has been gone to 51, 52 on an average. If you look at the miscarriage rate, I think that is significantly low, I mean significantly high after 37 age group, and that is what is age related fertility decline. But that's not important. We are dealing these patients through IVF. But can this age-related decline in fertility is affecting your IVF results? And that is what is this data shows, that as the age advances, the live birth rate after IVF cycle is also declining significantly after 37 age. So this is something that we understood is physiological. Now let's understand the pathological, that is premature diminished ovarian reserve. And these are the etiologies or hypothesis which says that why woman is facing low reserve at younger age, or probably even less than 35 years age. So oocyte, so there might be some chromosomal aberrations, abnormal FSH gene polymorphism, ovarian antibodies, reduced aromatase activity, decreased blood flow. Maybe there is compromised ovarian blood flow, due to maybe some adhesions or peri-ovarian adhesions or pelvic pathology. And the more commonly what we see is the acquired factors, that is obesity, chemotherapy, radiotherapy, infection, endometriosis, and heavy smoking. But we have to understand that obesity is prevalent in India, and how obesity is affecting. So one of the area where we see this premature decline is obesity, which is in a high. Basically in obesity, there are few mechanisms by which the ovarian reserve declines. There is a dysregulation at the pituitary ovarian axis. There is a disrupted meiotic spindle formation and mitochondrial dynamics that affects the oocyte quality as well as embryo quality. Then there are excess free fatty acids in reproductive tissues that causes cellular damage, and there is always a low-grade inflammatory reaction happening in the body. There are altered levels of adipokines such as leptins, which affect steroidogenesis and directly affect the developing embryo. And there is an impaired stromal decidualization, which actually affects the receptivity. So these are the mechanisms by which a obese woman faces decline in fertility. Now, what are those consequences? We know that obesity leads to PCOS with ovulatory dysfunction, insulin resistance, hyperandrogenemia. There is increased risk of miscarriage in obese women. There is an increased risk of diabetes and preeclampsia and metabolic syndrome. So we see during infertility treatment, these women perform at various levels. They give us very poor response, ovarian response. They give us little poor quality of oocytes. There is increased requirement of more gonadotropins in these patients. Poor pregnancy rate is there, and increased risk of miscarriage is there. It doesn't only affect female. So, when we discuss about declining fertility, it also affects male. So what happens in male when they are obese? So there is a lower testosterone levels. There are poor sperm quality parameters. Especially in obesity, there is an increased estrogen production and a lower levels of testosterone. And also, because of that fat deposition near pelvic area, there is a elevated temperature in the scrotal region, which actually causes oxidative stress. Okay, so impact of habits, that is our third area where we see a decline in fertility. Smoking, alcohol, and drug addiction. We need to understand that when we discuss this thing, especially in smoker, what we see is a significant decrease in sperm concentration and also the ultrastructural abnormalities. When we discuss about alcoholism, so semen volume, sperm count, motility, number of morphologically normal sperm, they were all significantly decreased in chronic alcoholic patients, and they have reported that current heavy alcohol users have significantly higher leukocyte concentration in seminal fluid, which affects their sperm quality. Especially in drugs, there are few data, but I think it has showed that cannabis exposure is a risk factor for a poor sperm morphology. So we see a lot of abnormal morphological sperms in cannabis users. We don't have any data on marijuana or
Really
cocaine.
sorry, but
Okay.
थोड़ा सा if you could
Fast
speed up
करूं?
थोड़ा सा please.
बैठ जाना
अरे सर
15 मिनट तो दे बात
अरे सर
करने के
मत
लिए।
करो ऐसा
ठीक है, all right, okay, I'll skip this. There is no choice. Shall I talk about it then? Okay. Okay, so I think this is one of the area where we need to little focus on declining fertility, and those are endocrine disruptors. Now, we need to understand from where this source of endocrine disruptors are happening, and that is what is happening in a woman's life presently. So her food is a source of energy for humans that we know, and it is one of the important sources of exposure to these deleterious chemicals, both natural as well as synthetic. So, what is happening, these endocrine disruptors, those are, considered as pesticides are one of them, fungicides are one of them, industrial chemicals are there, plasticizers are there, nonyl phenols are there, metals are there, pharmaceutical agents are there, and phytoestrogens are there. So it's a very serious concern that what we are eating or what pesticides are utilized for our source of food, I think we just unknowingly having so much ingestion of these pollutants, and they are directly affecting our endocrine axis, and that's why fertility we see now is that prevalence what we initially saw is increasing to 17-18%, and we are seeing more 40 to 50% patients which are attending our OPD having reduced ovarian reserve. So what are they? They are exogenous chemical and mixture of chemicals that can interfere with any action of any aspect of hormonal action, and they come from either we ingest that food, or it comes from inhalation, or it comes from dermal uptake. So there are three sources through which we have endocrine disruptors. Now they typically what happens, they go and get deposited into fat tissue, that is adipose tissue, and they have a pretty long half-life. Generally after exposure they don't immediately cause any affection, but they manifest at little later ages. So what they do, they interfere into synthesis, they interfere into action, they interfere into metabolism of sex steroid hormones, and that actually causing a fertility problems. And also there are certain endocrine disruptors, they are obesogenic effects, they disturb the energy homeostasis. So it has been documented in 2021 that we see lot of these patients are having high concentration of endocrine disruptors, and they are having positive association. And if you look at where exactly they impact due to this exposure, they decrease the estrogen levels, AMH level, antral follicular count, oocyte quality. So, what area it is pointing is totally on the ovarian reserve. So what we are seeing now that a lot of patients are presenting with low reserve at very young age. One of the very important area of focus right now for the cause of this is endocrine disruptors, and they are affecting and there are two types. There are something called as a persistent disruptors and non-persistent, but ultimately the impact is on ovarian reserve. Does it also cause an impact on men's health? So yes, they have been shown that these toxins exert estrogenic effect and anti-androgenic effect in men, and that alter the hypothalamic pituitary gonadal axis, and they induce the sperm DNA damage or cause sperm epigenetic changes. So this is one of the very important recent paper in 2022. That was around 79% studies, they included into this navigation study guide review. And they found that there is at least one significant association between pesticide exposure and reduced sperm quality. And I think it affects sperm quality and it affects sperm integrity. And that's why, what kind of pesticides are used for our production of, plants or vegetables, what we are eating, I think it is having a significant detrimental effect on the men as well as women's health. So to summarize, Declining fertility is a major concern in present world, and it is highly prevalent in most of the countries. And premature decline is something what we are seeing in ovarian reserve is absolutely rapidly increasing. Like it's happening like every third patient we see, and we see them kind of having significant reduction in the ovarian reserve. So lifestyle and poor quality diet are the main culprits behind this, and persistent exposure to these kind of endocrine disruptor chemicals are affecting ovarian reserve and sperm motility and sperm DNA integrity. So we must evaluate our patients for these kind of exposures, and counseling is very important to our young generation so that they may not land up in these kind of issues after maybe 10 years or 15 years or 20 years. So as a fraternity, all those decisions regarding surgery on ovary also need attention as they impact on reducing ovarian reserve, especially the endometriotic surgery and surgery like ovarian drilling. So if we do not pay attention to this problem, we are going to face increasing lifetime prevalence of infertility, and that's what is very, very important. So thank you very much for patient hearing
Thank you.
and for those extra minutes. Thank you.
Thank you, Kundan, for a very detailed talk. So what we think is that we should start making awareness in the school age so that they don't go to a longer elder age and exposed to a longer time for all this. So the earlier the better. So what I think is we should try to tell them that make babies should be your first apart from your other profession.
Absolutely, sir. I think we need to, the present patients which are coming to our OPD, they have already suffered. What is important is the future generation, and I think our counseling level should be there at that 13 to 18-year age group of girls. We need to counsel them that what kind of lifestyle what we are living and what kind of diet we are having, it's going to affect their future fertility, and unless and until we counsel that generation, otherwise this prevalence is going to increase. So I think
When we
that
talk
needs to be
about
done.
the future, we've got a panel discussion.
It
So
has to be the parents also should be knowing the things, so that there has to be the school and the teachers and the parents awareness program.
thank you so much. I would like to